Good afternoon, everybody. Thank you for attending to the session. The title of this session is Medical Certification. I am Prasanna Puhame. I will briefly introduce each speaker. Each speaker will be given 10 minutes. After 5 minutes, 3 minutes, and 1 minute, Beatrix will indicate the time. If time permits, we can have 5-minute question and answer session at the end of each presentation. If not, we can have dedicated question and answer session at the end. So please, you could write down the questions and we could ask them later. So we have excellent lineup of presentation. So let us begin. So the first presentation will be done by Dr. Yagnik Vasa. I hope I have read your name correctly. He's from Tata Memorial Center, our neighbor country. His title will be Assessing the Impact of Common Certifying Errors on Ascertaining the Underlying Cause of Death. Dr. Vignik is a public health professional with experience in CRVS and health system strengthening. He is also a country coordinator. He is attached to Tata Memorial Center. He leads efforts to improve medical certification and ICD coding in collaboration with the government and international partners. Our presenter number 2 is Dr. Vinay Sharma. He is also from Tata Memorial Center. His title is Improving Medical Certification of Cause of Death Quality through Physician Training at a Mumbai-based tertiary care hospital. Dr. Vinay is a research coordinator from the Tata Memorial Unit for strengthening cause of death. Is a participant of cohort 2 in CRVS Applied Research Training Initiative. The presenter number 3 is Dr. Elise Ekula. She is from the Ministry of Public Health. Her title is Implementing Digital Medical Certification through DHIS2 ICD-11 application in 35 pilot hospitals in Cameroon. Dr. Elise is a public health physician at the Ministry of Public Health in Cameroon. She is involved in national efforts to strengthen CRVS and mortality system surveillance, including coordination of cause of death coding activities. She has co-authored research on profile of deaths in hospital setting and contributed to development of national normative and strategic documents on CRVS and mortality. Let's start with presentation 1. Over to you.
Thank you very much, Dr. Prasanna, for the introduction. Good afternoon, everyone. I would like to first thank the opportunity for giving me to present at this esteemed forum. My topic, as Dr. Prasanna stated, assessing the impact of common certification errors in medical certification cause of death. On asserting the underlying cause of death. This topic was basically, selected, or we came to this conclusion, or this topic was, we are working in India to strengthen the mortality statistics and data. And we found that there are a lot of gaps in terms of training of doctors and correct certification. So this topic was selected on those lines as well. Moving forward, I would like to acknowledge my thanks, special thanks to the Economic Commission of Africa, ESCAP, the CART Initiative of 2025, my mentor Joanne Thomas, Petra, Nicholas, Nicola, Tanya, and the CART team. Into the importance now, over the past few days at the CART workshop, And at the forum also, we have all been speaking about the importance of accurate mortality data. We have been, speaking and talking about it, but a lot of work needs to be done in this area as well. So my study is partly will or might complement this as well. We have also been, and I would like to re-emphasize again the impact of, this important mortality data which it has. We speak about it's important for public health policy, it's important for resource allocation, monitoring indicators, and all those other things as well. In terms of gold standard, when we come to the cause of death, so a trained physician certified certificate is counted to be a gold standard for MCCD or cause of death. But how much does the physician certify this, or how many physicians are well trained to certify this? This is in context of the country which I come from, and this might also help to understand the physician's knowledge in terms of MCCD filling the form as well. WHO has defined underlying cause of death, the specific disease or injury that initiated the train of morbidity events leading directly to death. This is the definition. And in terms of Indian scenario, I would like you to take to the next slide as well. In Indian scenario, if you see, only 22% of death are medically certified. This is as per the 2023 report released by the Registrar General of India. Out of this 22%, also there's a big question mark, how usable is this data which has been collected? Are these forms just filled by the doctors who are trained? Is it usable at the national level for mortality data, for report generation? Is also a question mark. In terms of literature reviews which I've done is a study in a tertiary care hospital in Mumbai found that almost 100% of the deaths or the forms were inaccurate. This went on to have an urgent need for training of practitioners. In a study done in northern part of India, found that most common error was an inaccurate sequence of events leading to improper underlying cause of death coding. This is a brief slide which gives you an overview of the sequence of events which we have the part in India. If you go to see a medical practitioner certifies a form called the MCCD form, a trained medical coder codes the form, then it is sent to the local registrar. From there, the forms are compiled, sent at the state level, which is the Chief Registrar for Birth and Death, where it is tabulated and sent to the Office of Registrar General of India, where the yearly report for the MCCD or medical certification cause of death is generated. But if you see at the level 1, if a medical practitioner is not trained well, the whole sequence of events will not be good. The end report would not be good. It's something like the noise created at level 1 will amplify at the national level. So it's very important that we address this problem at the grassroots level, at the physician's level. In terms of coming to introduction, the role of an automated coding software. So I'll be using Iris automated mortality coding software. Basically, it's a free software. It ensures compatibility, reduces human error, and automated coding improves the timeliness, quality, and consistency of the coded data. The limitation of the software, as I mentioned in the previous slide also, would be that if the physicians do not fill the form properly, it would be garbage in, garbage out, which won't be usable as much. Apart from the knowledge, the problem is that little is known about how certification errors change the final underlying cause using an automated software. So my basic objective would be to categorize medical certification errors as major and minor, according to their impact on final cause of death. The research method, the study design would be a quantitative correlation study, where we will be taking forms from the state of Maharashtra, MCCD forms from the state of Maharashtra, 2024 forms from the year 2024. A total of 1,600 forms will be taken, selected via stratified random sampling, and the rapid assessment tool developed by the University of Melbourne would be used for quality control. So these are the 8 basic certifying errors which will be analyzed. To name a few would be use of multiple causes per death. Apart from that, the eight causes. It will be multiple causes per death, abbreviations, improper handwriting, to name a few. So basically, we'll be taking 200 forms from each of these errors, which will be compiled into 1600 forms, which will be analyzed. So my study would be a three-stage rectification study. So in stage one, the selected forms or the forms, MCCD forms, would be run through the IRIS software, and the final underlying cause of death would be derived, that is FUCOD1. In stage two, there will be partial rectification. In this stage, a clinical expert would rectify all the errors except the target error, and the forms would again run through the IRIS software to get the final underlying cause of death too. In stage three, the clinical expert would rectify all the errors and prepare a perfect form. This form would be run through the IRIS software to get the final underlying cause of death. So the expected results would be, the result of the study will help us identify which of the common certification errors have serious impact on the quality of final underlying cause of death. This will help us fine-tuning interventions in terms of training modules, online material, guidebooks, etc. for physicians on medical certification cause of death. This study would also give a taxonomical classification in terms of defining the major or minor errors based on the impact it has on the final underlying cause of death. Validation would be improved mortality matrix for epidemiological surveys and targeted interventions, as I mentioned, for medical practitioners training. This is just an overview of the slide of the above. So basically, if you see the inner circle, it would be the targeted major or minor errors, which will be derived from the study. Based on that, targeted intervention training would be for doctors. This would help in improving the medical certification cause of death at system level, and at system level, it will be help for policy brief and implementation at the national level. Next step would be, I have submitted my IAC approval. Once I receive the IAC approval, I will start data collection and plan the study as well. Thank you very much.
Thank you for the insightful presentation. Now we will open up for question and answers. Yes.
Thank you, Dr. Yagnik, for a very nice presentation. Just to be clear in my mind, in India, is it the medical practitioner who fills out the death certificate?
Yes, thank you for the question. In India, as per the RBD Act, it is important that a certified practitioner only fills out the MCCD form, who has a proper registration number, because the medical certificate requires him or her to mention the certificate, the number on the certificate.
Okay, so building upon that comment, working in, because I am from Pakistan, and probably the situation will be similar there as in my country, because in the government setup, doctors are pretty overworked. So how do you come across the barrier? Because doctors are very resistant towards added responsibilities, and this would definitely increase to their responsibilities. So has your country thought about maybe including nurses or training them on this, or what are your thoughts on that?
Thank you for the question. It's a nice question. I think so. My colleague also explained a bit about that. First of all, as per the Act, it is mandatory for a doctor to fill the certificate. He cannot deny it, whether it's a death within the institution or at the home. In terms of the burden, yes, the burden is quite high. This is an additional thing for the doctors who feel that, rather than giving time to filling the document properly, I have other patients to attend. This is one of the cause which is being seen. But we have at our unit for strengthening cause of death, what we have done is we have started training the nurses. Nurses also who can identify if the doctor fills the form, just to identify basic, as Sharwari mentioned, we have 10 pointers, basic 10 pointers, whether all the information has been filled, the time interval is there, whether there is no abbreviation within the form. So these are basic checks which we have trained the nurses for. And this helps us in monitoring the form completeness as well. Not the quality per se, but at least the completeness of the form.
Thank you, moderator. Thank you, Yagnik, for the excellent presentation. But I have particularly some methodological observation that I am an epidemiologist, so I usually focus on methodology particularly. That you are doing an observational study, and from an observational study, we particularly cannot decide that the causation. So, Yukta is trying, she is trying for an interventional study. So I will request you, if you really want to specifically say that we don't need doctors to be perfect administrators, we just need them to stop making the specific errors that breaks the machine. Particularly if you want to say that the error breaks the machine, we can also think in a different way. That machine should be modified in such a way that doctors can input that adjust with the system of the doctor's input. Because most of the digital systems are failing. Particularly, I work with digital health in Bangladesh, in Ministry of Health. So our digital intervention are failing because they are not accepted by the users. So what I want to say that if we can modify in this way, that we will develop user-friendly system that will be much more accepted. Thank you. Your opinion, please.
No, thank you very much. It's a very good suggestion. We should work towards making the digital platform or digital systems which are more user-friendly, acceptable by the doctors. This is one of the areas which we have been also working on. We have also tried to include in some of our hospitals in pilot stages the MCCD form within the EMR. For example, when a doctor tries to fill in the cause of death, automatically the iris code also is populated within this thing. So we don't have that error of coding done by a coder. So these are a few of the initiations which we are trying. As we also said, discussed also, AI is an option which we are looking at in the future, how AI can support or help doctors in simplifying things as well.
Thank you.
Thank you for your presentation. Congratulations. But I want to be sure that I got you well, because during your presentation, it's like you mentioned expected results. So is it a research protocol that you just present, or is it a result of a study? Because maybe I missed something. I apologize for that. So is it a protocol research or a research that you already carried out?
So I have not started my data collection yet. So these are the expected outcomes or results which I accept from my study.
Any questions? Yes.
Bonjour, merci pour...
Hello, good afternoon.
If countries have limited resources, would you recommend prioritizing improving physician certification accuracy or investing in automated coding systems, and why? Thank you.
So if a country has limited resources, which in India, we have an online software, but that software doesn't help in properly, and collecting all the cause of death events and the coding as well. So we also promote use of iris automated coding software, which will ease the burden of the coders and the physician as well. So this is one of the suggestions we have in terms of, easing the burdens for doctors as well.
Okay. Now, please note that we may not be able to address all issues, but we'll make sure that the question that you will raise will be answered at the end. And we will move on to the next presenter.
Thank you, moderator. Good afternoon, everyone. Myself, Vinay Sharma. I'm the research coordinator at Tata Memorial Center, Mumbai based, and I'm from India. The topic of my research is improving medical certification of cause of death quality through physician training at a Mumbai based tertiary care hospital. It's a pre-test, post-test study. So moving on, before starting the presentation, I would like to acknowledge my guides and my leaders of my institute, ACTRAC, Navi Mumbai, Tata Memorial Center, the leaders and the guide of my project, Dr. Yagnik, Dr. Sharwari, and my colleagues from Unit for Strengthening Cause of Death, and never to forget the ECA, SCAP, and the fellow Cartians who always at every stage helped me to refine my study proposal. And whenever I felt that my study is almost near perfection, it was a draft where I need to polish it again and again. So perfection is a myth is the conclusion which I have drawn from this journey. So moving ahead, I would like to brief what is the need of such kind of research or what is, at the global context. As we all know that CRVS has a very good role in strengthening it's a backbone of health surveillance, evidence-based policy making and resource allocation. But at the global level, the gap which is identified is death registration happens only registered deaths of 60% deaths which are registered globally. So that is a problem where 40% deaths are not registered. So basically, there are almost half deaths which is not registered itself. So that's a big global problem. When coming to the causes of death, mortality causes, it is in low-income countries, the data of WHO report shows 8% deaths are only registered with the medically cause of certificate, cause of death certificate. So only 8% population is known where what was the cause of death in that particular population. So if at all the data is not available, how can we initiate a policymaker or to intervention to control such kind of causes? So that's a big lacuna. At national context, as per the Registrar General of India 2023 report, it says that death registration in India is at 97.2%, whereas the medical certificate cause of death registration is 22% nationally, and at the state of Maharashtra, it is 42.4%. And Mumbai, which is the capital of Maharashtra, is having almost 100% death cause of death certification, because at the burial and cremation grounds there is a prerequisite of submitting medical certificate cause of death of each death, because of which the cause of death certification is never missed of any deaths in Mumbai. So considering Tata Memorial Hospital as my study site, it was the ideal place where I can work on the quality assessment of the MCCD forms, where all the deaths are being registered with the medical MCCD form. So considering the study site, there are various, I was focusing how to improve the quality of medical certificate cause of death at the study site. So as per the literature review, the probable solutions was the first one, physician training, second was digitalization, and another one was getting standard MCCD forms and SOP generation. But the most important point which was highlighted was the physician training. So hence I considered the title of my topic as physician training, and also to physician training so that the errors can be resolved at the source itself. So Hence, my study is focusing on the most appropriate method of resolving or improving the quality of medical certificate cause of death, which is by training of the physicians. So it was an implemented interventional training of physicians which was identified considering the research gap where the prior studies which highlighted only on the which stated that there were 99% forms which had at least one error. So that was a problem, and also as per the quality, it was also saying that actual forms were not analyzed to compare what is the outcome quality after the training. So if at all there were few studies which were saying that training is impactful, but we did not had the actual assessment of MCCD forms to provide the evidence in support of it. So after coming on the rationale, now I'm focusing on the methodology. The design is a pre-test, post-test study where I'm trying to compare, I'm going to train the same a group of resident doctors of our hospital, of Tata Memorial Hospital, and I'll be comparing 3 months before the training, what was the quality of MCCD form certified by them, and with the 3 months post-training, what was the quality of MCCD form certified by the same trained participants, doctors of the institute. So this is the comparison method which I will be pre-test, post-test study I will be doing, and include the sampling strategy is the convenience sampling, because as they are the doctors are working in the hospital as well. So as per the hospital administration, the batches and the availability for the training was decided. So convenience sampling was the method of choice. Now coming to the study phases, my study is going to be in 3 phases, where phase 1 will be the baseline quality assessment of the MCCD forms, where I will be analyzing what are the common certification errors by the certifying physicians, and what is the basic quality of forms which is they are certifying. Phase 2 is the intervention, where the training will be provided to the doctors, which will be a 2-hour in-person training, which will cover 4 topics, basically the importance of MCCD in CRVS. Second one is what's the standard forms which needs to be filled, and the third one is what are the common certification errors and how to mitigate them, and the fourth one is the real world general case discussion. And the third phase is the post-training assessment of the MCCD forms to get what are the common certification errors which is seen after the training, and what are the quality of MCCD forms certified post-training. So there was a standard tool as discussed by many of the speakers earlier session as well. It's the standard tool designed by University of Melbourne, which states that which identifies, it's an automated Excel based tool. So in that we just need to mention the common certification errors are present or absent in the form which we are assessing. So just on basis of that errors present or absent, it generates an automatic score, and on basis of that automated score, there's a category of quality certified, either on the basis of outcome score good, poor, or excellent. So the tool helps us to give us a standard tool gives us to give idea of the quality of MCCD forms. Now, as the study is for our institutional ethical committee approval, so we have not begun with the data collection, but the expected outcomes is post-training, the reduction in common certification errors committed by trained doctors. And the second one is subsequently there will be improvement in the quality of MCCD forms, and that will be signified statistically. So this is the expected outcome, and the global discussion will be, the results will be compared with the national and international standards. Second was, it will be providing evidence. It will be providing evidence in support of training of physicians as an actual method, best method in improving the quality of medical certificate of cause of death. And also it can be a reference for the training framework for other doctors in a way to have a training framework in which they can have a training sessions for their doctors of their institute or their region. So moving ahead, the timeline as per the IC approval, most likely I will be achieving that in April. And then in May and June, I'll be going on for data collection and analysis. And by July, August, manuscript drafting process. So at the end, I will thank you all. And I would leave you with the note that the motto is to get everyone in the picture, but my study, I'm with my study, I'm trying to focus that it's not just getting everyone in the picture, but also to get a proper background, pose, and get the quality out from the picture as well. Thank you.
Thank you for the insightful presentation and be on time. And now it's for question and answers. Yes.
Thank you very much, and congratulations, Vinay, for that presentation. My name is Stephen from Zambia. My question is, this is a very timely and important intervention, but I would have wanted or appreciated if you could just give what the current protocol is in terms of physician MCCD training as is. For the physicians that you'll be recruiting in the study, would this be the first time that some of them will be receiving MCCD training, or would they have had it as part of maybe their general medical training? I think that would be an important consideration to highlight as you conduct the study. Thank you.
Thank you, Stephen, for the question. A very good point which you have highlighted. And I had considered this point because what happens is for the baseline assessment of the quality of MCCD forms just before the training, I did not wanted the data to be biased, and hence in the inclusion criteria, I have included only doctors who are not undergone any kind of training for the last 9 months at least. So whether it's online and offline, just to make sure that the doctors are completely away from the standard knowledge and instructions and guidelines of MCCD certification. So the participants which I will be including in my studies won't be having any knowledge of, won't be undergone any MCCD training online or offline for the last 9 months just before the recruitment. Thank you.
Any questions? Yes.
Thank you, Vinay. I am from Bangladesh, and really being an epidemiologist is a very bad thing. Because whenever we see about the methodology, I know most of our here are not epidemiologists. We see some gaps. And I think we should talk about the gaps also, so that you may get easier way during the publications. Particularly 2 points. Number 1 point, you have told those doctors who have not got training in last 9 months. Particularly, I have learned doing measuring blood pressure around 10 years ago, but now I can also know. I can do that. So 9 months is not enough time for losing the knowledge about a topic. I think there are some behavioral sciences specialists, usually they tell at least 18 months. So I will request you, if possible, please do it 18 months, as you have not done it already. And one more thing, you have told the exclusion criteria that residents who did not undergo the study intervention. But there is a little bit mismatching. Mismatching is that you will take those who have not, who did not go undergo the study intervention. So this is already told in the inclusion criteria. So if it is not needed to write in the exclusion criteria. So I will request, if possible, please write those who received any MCCD training in prior 18 months. That will be very much helpful and scientific also. Thank you so much.
Okay. Thank you for your suggestions, Rafiul. Regarding the second suggestion, exclusion criteria, I'll definitely work on that. For the first suggestion, I would like to mention that I have mentioned that 9 months as in for the inclusion criteria purposefully because it was an observation that as you said that the example which you gave of measuring blood pressure from first day till it's a because it is you are doing on that regular practice on daily practice, but certification is not on daily practice for each doctor. So and hence there was a measurement of 9 months which was kept for the training purpose, and the implementation will be seen. And also there's a study outcome which is not published, and hence I'm not trying to say that, but the knowledge decay which you have pointed out, it is estimated to be 9 months. So hence I have mentioned 9 months in my study.
Thank you for the information.
So we will move. We will give you those questions in the latter part. We will give you in the latter part. So we will go for the third presentation.
Good afternoon, everyone. I'm pleased to present our work that is on implementing digital MCCD via DHIS2 ICD-11 in Cameroon, yearly results and listen. It's a pleasure because I'm going after 2 presentations that is a really concern, even in this study, because we are talking about deaf certification. It's not only to get the certificate, but is how do we get the certificate? What is the quality of this certificate? Who is certifying? I will also first apologize maybe for the quality of my English because I'm first French speaker, but a bit bilingual, so I will try my best to present in English. So our acknowledgement goes through the Ministry of Public Health of Cameroon, who gave us the opportunity to implement this strategy, this medical certification. Also to Vital Strategies via the Bloomberg D4H initiative, who have technically and financially support the entire implementation of the pilot and also the review of this paper, and the team, the pilot hospital teams and regional authorities who are the ones who are on the field to make possible to have this data. And we also thank the opportunity given to us by the forum and all the team that review our work. As introduction, we will compare 2 situations because first of all, we have to know that the journey of Cameroon starts with the cause of death really start in 2021, where we firstly talk about death certification and also ICD-11, because before the Cameroon did not adopt the ICD, neither the 10 or the 9 or any other version was not being used officially in Cameroon, and we was not certifying cause of death. So the mortality reporting was relying on paper-based monthly activity report, which aggregated all deaths into 36 broad categories. So you can imagine all the medical diagnostic was to be put in that 36 categories. So it was a real challenge and not specific data. Also, no standard medical certification of cause of death. So we don't even used the medical certification forms. Is only in 2021 that we harmonized the death declaration forms that include a part for death certification forms. Also, as I say, no ICD and weak interoperability between health and registration system. But we have the opportunity First of all, by the adoption of ICD-11 by the WHO in 2019, and since 2022, many countries are starting to implement it. We have also the development of the DHIS2 ICD-11 cause of death module by the HISP, Vietnam, and WHO that enables the digital capture and coding via DORIS in the health information system. And then the Bloomberg Philanthropy D4H initiative that is being through in Cameroon. And so based on all this opportunity, the Cameroon launched its pilot across 35 hospitals in April 2024, covering around 40% of national hospital deaths. You have to know that Cameroon is more than 6,000 hospitals, but not all the hospitals have medical doctors. So medical doctors are in around 1,000 hospitals, but we see that there is a concentration of death. So the 35 hospitals that we target concentrated 40% of death. For the method, we have been through implementation phase. This integrated stakeholder engagement. First, we have to sensitize stakeholders on what is the medical certification, why should we have to go through this journey, and how. And then having the engagement, the involvement on the stakeholders, we have to prepare the system and adopt a roadmap. So we adopt a national strategic plan for implementation of MCCD and ICD in 2024. The roadmap was for 2024 and 25. And then in this order, we have gone through training and capacity building. Training, we first have central training session that was for medical doctors and also what we call data manager in hospital, because in our settings is at the level of hospital that data is being entered in the DHIS2 module by the data manager. So we train them to capture the data in the system and to code. So we first started with a local codage. And then we see that big hospitals need another strategy. So in addition to the central session, we conducted on-site training for the big hospitals. And we also, during the pilot implementation, we've been through monitoring based on the data quality review that was conducted quarterly, and also training supervision, on-site supervision, to see what is the reality on the ground for each health facility, because we saw that every health facility have his characteristic. For this study, we embed the 35 public and private hospitals because the pilot is conducted in the 10 regions of Cameroon, so in all regions, rural and urban area, and in private and public hospital. As I say, is 40% of hospital death notified in the health information system. And the study period was from May 2024 to October 2025. We make the analysis as shown. For our results, we see that for the reporting hospital, among the 35, it's not all the 35 that have been successfully implement the MCCD. We started from two hospitals to in October 22 hospital was making the MCCD. So during the time with the different intervention as well as training and supervision and review of data quality, the reporting rate increased and also the certification coverage. So the percentage of death that was certified in that hospital passed from 3 to 40%. As we see here, we have gained in coverage and also in data quality, because from the 36,285 86 deaths reported nationally during the period by hospital, 52% was coming from that hospital, from the pilot hospital, and then we have 35 6,508 deaths. This corresponds to 9 to 18% of national death, hospital death. So we also improved the data quality because the certificate with underlying cause of death passed from 75% to 89%, and also we have a reduction on ill-defined cause calculated by ANA code from 37% to 37%. Also, we gain in the analytical value of ICD-11 coding because from our 36 aggregated cause of death, we have used 837 ICD codes during the period, and we have been able to identify some as early results leading cause like cerebrovascular disease, perinatal condition, and malaria. For our discussion, we can say that first, we see that the implementation is integrated in the global transition to ICD-11. Also, we have a distinctive implementation approach based, first of all, that we have directly transit to digital ICD-11, but also the direct integration of ICD and DORIS in the DHIS2 that is used in routine. We also see that we gain because of that specificity that can help for decision making and demonstrate that it's feasible to do it in a low-resource country. We have many factors that shaping the implementation, like governance and coordination, implementation enablers like capacity building, data quality management, digital tools, and development of national coding capacity, but many constraints too, like engagement of medical certifiers. As we see, they have other clinical constraints. We have the infrastructure gap network, legal framework, and organizational adjustment in hospital. For recommendation, we can recommend to integrate ICD-11 digital certification within routine HMIS to improve the availability, quality, and analytical value of mortality data. For the next step in our country, we aim to strengthen governance, legal framework, and quality assurance for death certification, expand ICD-11 digital certification to additional hospitals, integrate verbal autopsy to capture community death data most frequent in our context, and promote the use of standardized mortality data for health policy and international reporting. We thank you with this image of the first hospital doing the digital ICD MCTD in Cameroon in 2021. Thank you.
Thank you for the presentation. Your English was good. Don't worry about it. So now the floor is open for question and answers. Yes.
Thank you, Dr. Ellis, for that brilliant presentation and your efforts that your country is undertaking. In India, we are planning to transition from ICD 10 to 11. There is a long journey ahead of us. We are just trying to figure out what are the potential challenges that may be accounted during this transition. But since your country has directly transitioned to ICD 11, would you like to just share a few challenges that you may have encountered as a part of your experience? Also, is the digital MCCD form any different to the WHO 2016 international MCCD form? Thank you.
Okay, thank you very much for the question. First of all, as you said, is two different contexts because you may have some problem that we had not faced because it was new. So our main challenge is that you have to train something nobody have been trained to. So ICD is a new concept. You have medical doctor that feels that is like if you want to teach them medicine, if they have to refer to a book to give the diagnosis and you have to say, no, it's not this way. So it's really new. Our challenge is really that it's new. And we have the challenge of digitalization. So you have also to train them on how to use it. on how to use it. For that cause, we have done a paper base, but really ICD-11 is not aimed to be used on paper. So if you want to go through ICD-11, you have to get a digitalized system. This is the first point. For you, you will have to manage your historical data because you should not lose historical data. So how to manage the transition, keeping your data in ICD-10. For the question of the MCCD form, it's just a digitalization of the standard 2016 form. So it's not different, just that can be directly put in the system and we get the data. Thank you.
Yeah. Yes.
Thank you, Dr. Lees, for your presentation. So my question is that you mentioned that the research methods that you used was implementation study design, was it? So just if you can elaborate the methodology you used in here. Thank you.
Okay, thank you. We present the implementation phase just to put the context on how the data was collected, because we came after. It's true that we was embedded in the implementation process, but for this study we have just get the data, but the data is just to describe the context of having this data, that we present the different implementation phase that have been made possible the implementation.
Yes, you can ask a question.
Merci. Thank you for this presentation. My question, I want to know, by the project pilot, how did you choose these structures? How did you choose these structures?
Merci pour la question.
Thank you for this question. The choice of these these structures, like I said, we have elaborated a national strategy of implementation for the first 2 years, and the criteria were the performances of trainings, health training, and which with the good completeness. So this is our basis. A second criteria was the rate. Another thing was we have a system with different categories of health system, from 1 to 6, from large hospital to small. And we have included category 1 to 4, those who have specialist, non-specialist doctors. So we had to represent all these categories, and we need to have public and private hospitals, and we have privileged university hospitals to see what kind of impact it can have on the training of these medical students. So these were the main criteria to select these hospitals and structures.
We could go for the whole 3 presenters. You could ask the final Q&A sessions. There were some who had questions you could also ask. Yes, ma'am.
Thank you very much to all the presenters. Excellent presentations, and thank you very much for sharing your, the research that you've been engaged in and the great work that you're doing. My question goes to Dr. Vani Sharma. It's very exciting to see what you're proposing and what you're planning to do, and the ethical processes and that you have, especially with regard to MCCD. I'm curious, I'm going to ask you with regard to the methods that you're proposing. So you mentioned the quantitative aspect, and you mentioned that you are collecting and you'll be analyzing the data, secondary data. Is it possible to know in terms of, because you're talking about the quantitative, I was wondering in terms of the numbers, what is your sample that you're proposing to have? How many are those? And then you also mentioned in terms of collecting information from the doctors, after the training, pre-post. You mentioned in terms of your sampling strategy, the convenience sampling. And I was wondering why convenience sampling? There are many other methodologies that you can use. I mean, when we talk about convenience, we talk about the fact that it's very quick, low cost, easy to find someone, many times used by also media. But I was wondering, have you thought about using the purposive sampling, which is more rigorous in terms of getting the in-depth insights, but also very, very important in terms of getting insights with regard to experts as another methodology, if you want to look at it in terms of the qualitative? I submit.
Well, thank you for the question, Alan. Definitely, I'll look into how I can opt for a better sampling method, apart from the one which I have selected. Answering your first question, it is the sample size. I'm going to recruit all the forms certified by the trained medical practitioners, which will be for the time period of 3 months before the training and 3 months after the training. So I will be assessing all the forms certified by the trained practitioners for the 3 months before and after the training period. And as the hospital, the site where I'm going to conduct that study is a 700 bedded super specialty hospital, cancer hospital. So there are almost around 1,500 annual deaths. So my sample approximately, which I can say is around 300 to 400 in the baseline assessment. I will be doing of 300 to 400 MCCD forms and almost equivalent of equivalent forms post training as well.
Yes. Yeah. Yes.
I wanted to propose that you can still have a sample. You don't have to go through all that. And the reason I'm proposing that, as long as you can be able to draw your methodologically sound sample size, it is okay. Otherwise, you'll be there forever, because you talk about over 300 forms and all that. You have an abstract form, collect, and then you can be able to scientifically analyze the data in addition to the qualitative insights. I submit. Thank you.
Thank you. Yes, ma'am. You had a question? Yes.
Okay, my question is for Dr. Vinay. I was thinking that you are conducting a 2-hour session and then evaluating your study. So do you think it's enough, this session would be enough for you to get some significant results? Or maybe you could think about developing some short module which the doctors can take over like 5 days and then take a test, because I believe you have some funding for this project, and maybe like in United Nations there is this pre-induction training, I believe. So do you think that could give you better results? So something that doctors can turn back to if they're in confusion while reporting? Thank you.
Thank you for the question. A very good suggestion. But the thing is, first we need to see the baseline, basic 2-hour training. What is the impact? If at all that is impactful, then we can propose further for a long-term training, or perhaps a refresher training on annual basis.
No, what I think that wouldn't it be more economical to develop this online module rather than the 2-hour session that you're planning to have?
Yes, a very good question. Suggestion. The thing is, we have an online module as well, but that is a 4-hour training e-learning course which is there on Omnicurus platform. So on that there is it provides an certification, a completion certification as well. we are promoting that e-learning course as well. But along with that, if at all there is a 2-hour in-person training that helps to resolve the queries of the participants on the spot itself. So, and hence we are advocating 2-hour training module in this particular study.
The questions, I think. So you had a question. Yes.
Merci. D'abord, félicitations à tous les.
Thank you very much. First of all, congratulations to all the presenters. My question will be mostly to the first presenter, doctor. If you can have a look. So I asked myself, and I will take inspiration of the experiences concerning the verbal autopsy. So this is concerning verbal autopsy. I'm wondering if the IRIS software is getting better. Is there a better coordination with IRIS when you integrate some data, the rules, the inference rules leading to the conclusion? Is it getting better? Or what bias could there be? Because I believe that more and more practitioners and physicians are getting used to the certification. So maybe they could bring some extra expertise within the certification itself and share their experience. And so is there quality control, internal quality control mechanism when it comes to the certification as well? That's my question. Thank you very much.
In terms of the automated coding software IRIS, IRIS will give you quality control. If we run, for example, if we run one form twice also, it will give the same underlying cause. That is one of the aspects which IRIS comes in with quality control. And to answer your next question about the verbal autopsy, this won't be taking verbal autopsy. This only basically forms at the institution level within the hospital. This is to answer. I hope I've answered your question.
Thank you. Give me the opportunity. I am Dr. Husnaira Parveen from Bangladesh. It is not a question. It's my recommendation or any. When I did medical certification of causes of death evaluation for my academic work, my supervisor advised to talk a person who came from Sri Lanka named Nandalal. In Sri Lanka, there have a rules. When a person completed his medical school, he must be complete the training of medical certification of causes of death. When he or she, if he or she doesn't completed this certification, he cannot get a proper certificate from the government. So they are more competent from Bangladesh because we cannot start this service. So in this forum, I recommended all of the country that if we can start this system, hope that we can remove more error and should MCCOD certification is more correct. Thank you.
Thank you. It's a very good suggestion. In India also, what we are trying to do is inbuilt these kind of modules within the curriculum of the interns, residents, postgraduates. So what happens is when they move out of the system, they have certain basic knowledge about MCCD. We have also written to our National Commission, National Medical Commission, to include this. It's in the technical evaluation phase as of now. And for the integrative medicine, apart from the allopathic medicine, we have also proposed to them as well, because there are also a big, huge number which we have in our country. So these proposals are in place. These are good recommendations, and this helps us build capacity in long-term sustainability as well. Rather than conducting trainings over and over again for the doctors, this becomes an inbuilt model within the system which would last long. Thank you.
We can have one last question. Yes, sir.
Okay, thank you. Thank you very much. So, congratulations to presenters for their presentation. So, I have one question to the second presenter. I would like to know, is electronic health record used nationwide in India or in Tata Memorial? Because if the paper base is used, your result can be biased because beyond the training, there is a problem of data quality and data availability in the patient health records. Sometimes physicians complain about the lack of information on the patient who diseased. So, did you take it into account in your methodology before analyzing your results?
So in the institute where I am going to conduct this study, it is paper-based NCCD forms which is certified, and but there is an EMR as well. So whenever a doctor is in doubt whether what was the actual medical records or the causes of death ascertaining, so he can definitely review the EMR of the patient and get the actual medical record and accordingly certify and ascertain the causes of death on the NCCD form.
Okay, now it's 4 o'clock and we will conclude our session. I encourage you to continue the discussion once we finish this. And I would like to thank everybody, the wonderful speakers and all of you for engaging in this event. And let's give a round of applause to all the great 3 speakers. And enjoy the rest of the CRVS forum. Thank you very much.